Thank you, Joe. It is with pleasure that I introduce our keynote speaker for the Spring 2015 RA, Dr. Bill Cavers. Dr. Cavers has a remarkable background, starting out his academic career in zoology with a focus on genetics. He received his medical degree from the University of British Columbia, interned in New Zealand, and worked in Australia before he set up a family practice in Victoria, BC, where he has been for 35 years. After a long involvement with Doctors of BC, or the BCMA as it was then known, which stretches back to 1995, Dr. Cavers became president of the organization last May. He served for 8 years as co-chair of the General Practice Services Committee of the BCMA, playing a central role in reshaping primary care. Dr. Cavers has focused on 3 key areas during his time as president, areas that we at the SMA have also been focusing on, including physician leadership and professionalism, physician engagement, and physician leadership. I am pleased to welcome to Saskatchewan Dr. Bill Cavers.
It sounds so impressive when on my side all I did was get older. So I want to thank you for inviting me here today. It's an honor to be here. And I want to clarify that I'm not here as any expert on collegiality. I'm here simply to tell the story of what happened in BC over the last few years and how we have partially pulled ourselves back from a brink. So I'm going to tell the BC story. We went through a period of time that we call the Dark Ages. Back in the 1990s, we lost a considerable amount of commonality in terms of mutual training. We lost the rotating internship, which put us all together. And also, medical students were faced with making choices in the third year, which started spreading them into different streams of training, reducing the commonality of experience. GPs left the hospitals in droves, and not just about the parking issues. And as a result, many specialists also left the hospital as well, and we lost the commonality of workplace, and long gone are the days when we used to meet together in the doctor's lounges of the hospital, have coffee and talk things over. Because of the lack of commonality and the lack of interaction, we lost some mutual understanding. Who are these people that I've been referring to or getting consults from? Who are these people that are referring to me? What do they do and how do they operate? At the same time, in BC, we were facing a provincial government that ideologically was determined to marginalize the profession in influence. A deputy minister of health in BC was heard to say, quote, "Putting physicians in charge of healthcare is like putting Dracula in charge of the blood bank." So we made, as an association, a decision that was good in the short term, but not good in the long term. We started focusing on economic gains. How could we maximize our economic advantages if we're not going to be able to get anywhere in professional influence? That's sort of the manifestation of they don't pay me enough to put up with this. And that changed the discussions. It started focusing because the contractual gains we got were so small. It started focusing on competition for the small rewards and a focus on disparity and competition for them. And that created a huge erosion of goodwill between the sections, between physicians. It was bad. I was involved with a section of general practice and I was receiving hate mails, emails. And I can't tell you how many times I had to literally clean spittle spray off my glasses. A colleague of mine in Victoria, when he was entering the hospital, was told by a colleague, a mutual colleague, that you'd better hope you're never admitted under my care because I'll make sure you never walk out of here alive. It was that bad. So, the start of the change happened in 2002. It was at the end of a contractual negotiation in which we had to go to mediation. And then the government stepped in, legislated the mediated settlement out of existence, and that it was never to have even existed. It was a bad time. But out of it, there was one little nugget of gold, and that was a collaborative committee called the General Practice Services Committee. It was a joint government of BC-MA committee, and it was focusing on quality improvement. It was not focusing on negotiations. Its mandate was to encourage and enhance full-service family practice and benefit patients. It was designed to focus on clinical care gaps for complex patients, and it was focused on improving quality care. And there was, brilliantly, a contractual obligation for evaluation, and the evaluation has proven the value of primary care and ongoing care in treating patients. Result, we started getting some pretty good relationships with government, and we got some good initiatives off the ground. In 2006, the change really happened. The successes that were seen at the General Practice Services Committee were enhanced. First of all, the GP Services Committee budget, because the government saw an investment in quality care and an investment in being willing to evaluate their own performance, they increased their investment from $10 million a year up to $146.5 million a year over 4 years, and that investment is now topping $220 million a year. Two other committees were also formed, the Specialist Services Committee and the Shared Care Committee. Specialist Services Committee, to collaborate with specialist physicians to improve access to needed evidence-based quality services to meet patients' medical needs for optimal health outcomes, again, a quality agenda. And the Shared Care Committee, to enable shared care between general practitioners, specialist physicians, and other healthcare professionals. So I'm not going to go into all these things, I'm just going to step across these, because it's more the story and the points I want to bring to your attention. The GP Services Committee, first of all, deliberately went into some fee schedule reforms in unleveling the playing field in fee-for-service. As we saw, walk-in clinics were cherry-picking, and the general practice community was switching more into episodic care. The importance of this was that for the first time, full-service family physicians saw a major investment valuing their time in providing the care for patients and taking on the responsibility. We brought in chronic disease management ones, complex care fees for patients with comorbidities, planning fees for people with mental health issues and for end of life, and very importantly, conferencing fees, so physicians were paid to actually step back from the face-to-face care and talk to their colleagues. And under the mandate of the GP Services Committee, there was non-compensation funding. Non-compensation funding that was put towards a program called the Practice Support Program that brought in two arms. One were learning modules so that general practitioners could actually, for the first time since leaving the hospital, get together and talk about things other than fees. We started talking about quality care and how to improve care and how to improve our skills. And those are some of the modules that were introduced. The other arm was in the area of practice efficiency, bringing in advanced access scheduling, group medical visits, patient self-management, and practice and EMR coaching so that people who were having difficulties with practice efficiencies could receive coaching, and we actually got some training in how to use our EMRs effectively. Then, in 2009, the GP Services Committee adopted the AAA. Now, I understand that the Saskatchewan Medical Association is also very fluent with the AAA. I'll go over it anyway very quickly. This is very important to the doctors of BC. Three aspects, 3 points of the triangle. One is addressing the per capita cost of care. The second one is improving the population health. And the third aspect has a BC twist to it. The Institute of Healthcare Improvements, AAA, simply states the patient experience of care. The doctors of BC imported saying the experience of care by both the patient and the provider. And that initiative, the AAA, has now been formally adopted by the doctors of BC as a lens to shape any initiatives and a way of evaluating initiatives when they're done. The next big step was out of fee initiatives and away from practice training into creating structural changes in primary care. We created divisions of family practice. We plagiarized the idea from Australia and modified it for BC. So divisions of family practice are community-based groups of physicians who get together. They're organized as a non-profit society, and they receive funding for infrastructure support, for staffing and for meetings, etc. And they are set on a quality agenda. They are going to look at patient care gaps in their communities and look at how to best address them. 3 of them were formed in March of 2009. There are now 34 divisions across the province. 95% of the family doctors of British Columbia have access to a division. So right now, with the divisions being formed, we also had to giddy up, and we had to actually provide some leadership training to physicians, because we were asking them to step forward and be physician leaders. So right now, through the GP Services Committee, we have trained 130 physicians to be physician leaders. And the most ambitious program has been launched in BC, and that's called a GP for Me. And the stretch goal is that every British Columbian who wishes to have one will be able to access a family doctor. It was launched in 2010, and it required an awful lot of cooperation between the Ministry, Doctors of BC, the local divisions, and the health authorities. 33 of the 34 divisions have voluntarily taken this on. The one that has not is newly formed, and they just didn't feel it was within their capacity. So I want to go to the other committees, and there's a flavor here. The Shared Care Committee, which was to address the interface between specialists and GPs, brought in a number of initiatives. They brought in Partners of Care, which was to improve the relations, the flow of information in terms of referrals to specialty care and consultations back from specialty care. And it actually required that GPs and specialists of different disciplines get in the same room and agree what they wanted. And not only that, it actually required that some of the specialists of the same discipline would get together and agree on what they wanted. So 35 initiatives were launched across BC. The gastroenterology GP division initiative brought wait lists down by 74% and wait times 85%. And you can see that the respiratory GP division initiatives reduced hospitalizations for COPD by 32%. We brought in what's called a race line, rapid access to consultative expertise, in which community practitioners could phone to get expertise in areas in which they needed advice. We're using a Panago pizza model. We're using the same phone number, but now, since we're spreading it across the province, when a community physician phones, they get access to a local specialist, one with whom they're going to be dealing with again. So again, we're fostering relationships. And the fishing for pearls, we get GPs and specialists together in a room, and the specialists provide the community practitioners with ideas of what is really important that they know in terms of ongoing care, the pearls that they've learned over the years. And has been immensely successful, again, creating an arena in which general practitioners and specialists engage in clinical care discussions. We also used other initiatives, transitions in care, the same type of idea for the transition for patients in and out of hospital. And the most recent one is the virtual prenatal care in rural areas. We have patients going to a family doctor's office and using an encrypted video conferencing program are interfacing with maternity care providers in other communities. And if you want that, a really neat video, there's a website down at the bottom there. Province-wide, again, bringing in the interface between practitioners on a clinical basis. Teledermatology has brought 11 dermatologists and providing services to hundreds of patients, incredibly valuable. I can take a picture of a rash or a skin lesion, send it to a dermatologist, and I get the best advice back within 24 hours. And it has also reduced their wait lists. Rapid access to psychiatry, another initiative. again, reducing patient wait lists, providing care to 4.5 times as many patients in the same period of time, incredible increase in patient satisfaction and provider satisfaction. Same with the polypharmacy. The most ambitious initiative under shared care is the Child and Youth Mental Health and Substance Use Collaborative that was started in the Okanagan. And this has required collaboration between multiple partners. The Ministry of Health, the Ministry of Child and Family Development, the Ministry of Education. Try to get them in the room and see how easy it is. With us, the Doctors of BC, with the Divisions of Family Practice, the RCMP and the school counselors, local governments, we brought in the patients as partners as a voice. So currently it's spreading across the provinces, addressing reduction of barriers to care. So this is all going over. The focus of the initiatives is on clinical care, improving clinical care, reducing gaps in care, improving the physician's sense of self-worth, and putting physicians of different disciplines together in the same room to talk about these clinical issues. I was privileged enough to sign our new contract on December the 5th of this year. And I'm happy to report that the same culture that has been so successful in divisions is now moving into the health authorities under the facility-based physician engagement. So now physicians that work within hospitals are being given a voice of meaning and influence in terms of budget allocation, resource allocation, and their workplace environment to address patient care. We have 2 prototypes right now on the North Shore in Prince George. In the fall, we're going to be spreading it out to 4 to 6 more sites, and we already have 15 sites that want to join. I'm not going to read this. We had a whole bunch of different meetings. Call them forums, call them fora, I don't care. But we had a number of different meetings of physicians in the same room talking about clinical issues, practice issues. So, commonalities. We started switching the focus away from fees, away from disparity correction, took that off the mainstream. We started looking at focusing on provision of care, improving quality care. We invested time and resources and money into initiatives to build relationships between the different types of physicians, and that actually enhanced the professionalism and the quality of interactions immensely across the profession. Here's a front page of the Doctors of BC. Oh, that was at BCMA. We were still at BCMA when this came out. That's our paper on professionalism. It's on our website. And there's a reason why we formed that paper, because we weren't doing very well, even as shortly as a few years ago. So I was asked to recommend, what can you do on Monday or Tuesday when you go back into the office? And I was thinking, what can you do on a community level? Start forming local groups of physicians who are focused on providing care to patients on clinical. I did not go into medicine, I don't think you went into medicine, to start arguing about fees or contracts. 2, form intersectional, interprofessional relationships in groups. So if you're going to get together in clinical groups as one section or other, cardiologists looking at a specific type of care, as quickly as possible branch out so you're dealing with other specialties, other disciplines as well. Put the focus on quality, on improving care, and improving the experience of care for yourself and your patients. And provincially, I would recommend take the negotiations off center stage. Spend your time developing a process for how to do it, and then let the process do it. And I'm trying to say automatize, that's not the right word. Focus on the process and externalize any mediation, so you're not having physicians in the same room screaming and yelling at each other, arguing about different things related to fees. And actually invest, provide supports, human resource supports, financial supports for developing clinical care issues and intersectional relationship building. And as a last slide, I just thought of, since I also am a twit, I want to put up this thing that I found on the web just a little while ago. I think Bonnie Brosser's tweet sums it up, and I think you're in good hands, and I think you're on the right road. Thank you.